treating seizures before they even happen. A special brain implant is already changing the lives of people with epilepsy. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Seizures can be scary, of course, for the person having them and even those around them. Today, we meet a young woman whose seizures started in the 5th grade. She lost friends. Later, she lost out on job opportunities. But today, she says she feels like a whole new person thanks to that special implant. Let's learn more from Mallory Contreras. She had a responsive neurostimulator, an RNS, implanted back in 2020. Good morning. Good to have you, and thanks for being here to share with us your experience and how you're doing today. We also have Dr. Patrick Landazuri. He is a neurologist specializing in epilepsy, aka he's an epileptologist. He's one of several experts working in our Comprehensive Epilepsy Center here at the University of Kansas Health System. So thank you both for being here. So Mallory, your seizures started in the 5th grade. You told us you don't really remember much about that first one, but those seizures kept happening time and time again. Tell us a little bit about the frequency of them and what you do remember.
Like that morning that I had my first seizure, I had a really bad migraine. And it was one of those things you just kind of take the Tylenol, you feel better going to school. But after I had gotten to school, you black out with the seizures. You don't remember having it. Just kind of one of those bad days. And they had called my parents to just pick me up because I hadn't officially had the seizure yet. And when they had picked me up, I had one in the parking lot. And we'd never seen that before, you know.
This came out of the blue. Parents had no idea what they were looking at.
Yeah.
And what were you feeling? Did you know something was wrong in the moment?
I don't really remember that part. I mean, and it's so different, especially when you're little. And from then on, it was having seizures like 2 or 3 times a month, if not more. And knowing nothing about it, I was trying to figure out what was causing it all. And
right. Dr. Landazuri, since she can't remember and explain what is happening during a seizure, tell us.
Yeah, so I know that Mallory has temporal lobe epilepsy, so many people do have some kind of warning that it's going to happen. Oftentimes they don't remember it though, and so they only know it if you ask them right at the moment. And the reason for that is the temporal lobe helps with memory. So if you scramble those memory circuits, you're literally not going to remember. People then can progress to a period of unresponsiveness, and then the convulsive part of the seizure that I think everyone knows so classically.
Right, right. And when we talk to epilepsy patients, I mean, we always have to go way, way back to the beginning when they were young. Again, 5th grade for you. You shared some photos of you back in middle school. You played sports, basketball, volleyball. Of course, epilepsy got in the way. How so? How did that limit you?
Being a very physical activity, it's why I would have a seizure in the middle of a game or something after running for so long. It would just cause an episode, and
you just eventually had to pull out?
Yeah, couldn't do it anymore.
What was that like for you?
It was very hard. You know, you have all your friends that are on the team and something you like doing after school. Had to just find a new hobby.
Yeah.
So I decided to join the band and did that.
What'd you play?
I played the clarinet.
That's what my daughter plays. Good, good. Okay. So you lost friends, though, because of this. You have to back out of sports, find new friends, but you lost friends. Why do you think that was?
Just because they didn't understand, and people see things on TV and automatically assume that everything they see is true or everything they hear is true, and just not understanding what it really is.
And young kids, and Dr. Landazuri, I'm sure you can imagine, it's hard for adults to really understand what's happening with somebody with epilepsy, but young kids trying to understand and navigate and how to handle somebody having an episode, I would imagine.
Yeah, I think when people see people have seizures, it's deeply concerning, and at the same time, it's also deeply alien. So people just kind of want to be away from it. I remember the first time I saw a seizure before medical school, and you're kind of like, what is happening? And it seems too much to handle. And I think, you know, for an adult, it's like that, and I can't imagine what it's like for a 6 or 8 or 10 or 12-year-old.
Right.
Yeah.
Right.
Yeah.
Is that kind of how you were feeling and thinking about that? Did their perception change over time, or did you just get a new group of friends that kind of grew with you?
Just kind of got friends that would grow with me and learn about it. The older I got, like in high school, I met new people that had already known. They knew a family member that had had it, or the job that they wanted to go to, they had to learn about it. So.
Yeah, that's really nice to hear. Of course, your family stayed really supportive, especially your little brother. Tell us a little bit about him, how he helped you through school. I guess in some ways he was like your best buddy, right?
Yeah, my brother is 2 years younger than I am, so we were in school a lot, and I couldn't drive, so, and not having the friends or, you know, to get to practice and stuff, my brother was like, oh, just come with me, you know, we'll do it. So it wasn't very uncomfortable because it was a family member helping, and making sure I was okay if something would happen. He was always there.
A kind of a nice, sweet thing to happen, because siblings at that age, going through high school, and so a kind of unexpected relationship and bond I'm sure you both had. After graduation, epilepsy made it hard for you to enter the job space. Were you fired from a job? Is that what I understand?
Yes,
Tell us about that.
They had seen me have a little episode. It wasn't necessarily a big seizure, but it was enough for them to be uncomfortable. And they just said, it's too dangerous to have you here. We have to let you go. And with that, I couldn't find another job. Everybody just saw epilepsy and didn't want me there. Scary.
These stories that you hear, like Mallory's, is that pretty typical?
Yeah, unfortunately all the time, and it's really disappointing since epilepsy is protected under the American with Disabilities Act. But I've been watching all these pictures of Mallory kind of go through, and I think everyone can see she's entirely normal, and everything is perfectly normal, and it's really frustrating that she's treated like she's not.
Right, and we can acknowledge that you actually did not treat Mallory,
absolutely.
but you treat patients like Mallory.
Yes.
So and you've heard these stories again and again. We've talked about what a seizure is, but just, if you can, kind of in the basic terms, explain epilepsy.
I would say that epilepsy is a disease where seizure is the main symptom. There are actually many symptoms of epilepsy. But a seizure is essentially just a misfiring of the brain. So if we have normal brain electricity, brain waves that are telling our body to have this conversation right now, imagine all those suddenly went to a screeching halt, and then it did something else without our permission, without us knowing about it. This is just complete stopping of normal activity, and then the seizure happens. And I think Mallory's unfortunately experienced that too many times to count.
So let's talk about the evolution of treatment. You take us back a few decades. What would have been the first line of treatment for, is it kind of a one-size-fits-all?
Sure, we can even go back centuries. So the first century was actually surgery, which we'll talk about here in a second. But the first modern treatment was actually bromide in the 1800s, which is poisonous, so we don't use that anymore. But the first modern treatment was phenobarbital, and that was in the early 1900s. We've since evolved to having, we must have 30 or 40 seizure medications at this point. So medicines are the gold standard of treatment for epilepsy, and the reason for that is because 70% of people take medicines and are seizure-free. It's for those 30% that aren't seizure-free with medications we consider surgery for.
So you hear a lot of these similar stories, but what's nice is everybody's case is different at the end of the day, and so you have these different treatments to be able to treat that, right?
And absolutely, and every person has a different priority or different need in how they want to be treated, and so it's nice that we have all these options these days.
So let's talk about RNS, this implant. Explain to us how it works, and then I'm going to show you what it looks like.
Yeah, so basically, you can think of it as a defibrillator for the brain. So it's implanted in the head, and I think there's a graphic going right now. And so that implant, what it is, and it's in the skull, and then there are wires that go to the specific part of the brain that Dr. Uysal, my partner who treats Ms. Contreras, put in. And so basically, those are always on reading brain waves. And so when those brain waves misfire and turn into a seizure, it sends a jolt of electricity to that specific part of the brain in an attempt to interrupt that abnormal brain electricity. And then I think we're gonna have a picture of showing that working for Mallory, actually.
Yeah, I think we have some snapshots of her brain waves, if we can pull that up. So what are we seeing here? That's a lot of squiggly lines. Tell us what that is.
Yeah, so basically this device allows us to put 2 different electrodes in someone's brain. So for Mallory, she has one in each of her hippocampuses. These are in the temporal lobe, and this is where her epilepsy starts. And so I'm sure everyone can see the top 2 lines. That's the seizure itself. And so you can see the x-axis is time, and so you can see within a second or two, the device has been programmed by Dr. Uysal to recognize this as her unique seizure signature, and then it sends that jolt of electricity, and this only shows the first 10 seconds. It did stop the seizure for her, so so she's never clinically aware of them.
Okay, so you had a nice parting gift of a keychain of exactly what this RNS device looks like. So this is the actual size. I'm going to show it here just so you can kind of see it from like my hand. But so obviously you see the curvature of it, and then it's just attached. I mean, this is a kind of just a model of what it looks like, but very accurate.
Yeah, it looks exactly like that. Our neurosurgeons do a fantastic job putting it in. So it sits in that skull, and then the wires come out of that top part where the keychain part is.
Okay.
And they'll have four little wires come out of that at most, and then it just sits there.
And this is the weight of it too.
Yep.
And how's it attached?
It sits in a little tray,
okay,
and then it screws into that tray so it doesn't float around or anything. Obviously, we don't want it moving around Mallory's head.
How new is this technology?
It was FDA approved in 2014, I believe. It's been under research since the 90s. It was actually developed by epileptologists, and one of the main ones is still kind of the chief medical officer of that company. And then the pivotal trial for it, I think began in 2004, I believe.
And how impactful and important is it to patients?
It's huge. So as I was talked about, I think the great thing about being an epileptologist right now, besides the patients, of course, is that we get to offer all these different options to people, and people have very different thoughts. I mean, sometimes we can remove a small portion of brain. Sometimes we do a brain stimulator like Mallory has. Some people don't want surgery at all, but now we have so many options, people can really choose their own path. And I think people who are also very scared of removing a part of the brain are more open to perhaps a brain stimulator. And I think Mallory was probably open to whatever might have come out of it. But some people, it allows them to go on a path that they wouldn't have otherwise gone on.
So Mallory, you hear this as an option. What did you first learn about it, and what questions did you have?
It almost, to be honest, seemed too good to be true that it was possible that it could do that. And kind of, like he said, I didn't want to go and do something so major as to removing a part of my brain, so it was a nice thing to try out.
And how are you doing today?
Great. Haven't had a seizure in about a year.
Wow.
So, yeah.
And is that what we're seeing typically, Dr.?
Yeah, so I think you got yours implanted in 2020, is that correct?
Yes.
So when we put it in, there's a kind of, I won't say a trial period, but a period where we have to kind of mold it, to individualize it to the patient. So getting those settings directly in, and then changing how much current is delivered when she has a seizure, that's very individual. And I know you and Dr. Usal probably met every 2 or 3 months for a fair bit, to make sure that we're getting those symptoms so you can be seizure-free for this year.
So Mallory, can you tell when it's actually working, when it's like intercepting a seizure?
There at the beginning, it was kind of hard to tell because, like the doctor said, they had to find the so-called sweet spot for what's going to happen. And when I noticed it start working, you get the aurora, the funny feeling before the seizure. And usually it lasts a couple minutes for me, or a couple seconds. And I would tell my mom or whoever's around, I'm going to have a seizure. Oh, wait a minute, it went away. Okay, never mind. And later on, when Dr. Uisal would show me the graph that they just showed you, he would say, okay, yeah, this is where the RNS stopped your seizure. So you started to feel the very beginning, but it stopped.
So tell us the difference between that and the deep brain stimulator. We talked about that in the past, but tell us the difference between that.
Yeah, so the deep brain stimulator goes to a part of the brain called the thalamus, which is kind of in the center of the brain. We have a left and a right one, just like most things in the brain. And so it stimulates kind of the way that the seizure moves throughout the brain, whereas the RNS stimulates where it starts itself. And so that's why we like to use it a fair bit.
So several million Americans we know have been diagnosed with epilepsy. Who is this best for? If someone's listening, who would say, that might be for me?
Yeah, so the definition of drug-resistant epilepsy is failing 2 medications. And if you fail 3 medicines, less than 1% of people in the situation become seizure-free with medicines alone. So after you fail 2 or 3, it's talking to your neurologist saying, you know, what else do we have besides medicines? Because your odds are low. It's not that neurology, we're medical doctors. We would prefer to do it with medicine. I'm sure Mallory would have preferred to be seizure-free on medicines as well. But for those folks that aren't, we ought to be considering that. And it's a standard of care for epilepsy patients.
Mallory, how's it changed your life? What's the biggest thing you can really hone in on?
It's totally different, a new life altogether. Being able to be alone now, people not having to worry about me, what I'm doing, or if I'm okay.
Was there a time you had to live with somebody? Tell us a little bit about that.
Yeah, I had to, after high school, try to move out, and I had to move back with my parents, and just not being able to get out on my own, having to call my parents all the time.
Do they worry about you still?
Yeah.
I bet they do. I was going to say, that's hard to let go of, but they must feel better knowing that you're out there living life.
Yeah.
The way a young mom like yourself should. And we're going to talk about your daughter, because we know there's a lot of misconceptions when it comes to epilepsy. That's what we're learning here this morning. And I actually did not know this, that it may prevent somebody from starting a family or getting pregnant. And so I want to dive into this. So Mallory, you're a mom to a beautiful daughter. Let's show, this is little 5-year-old Natalia. Was there any special care or concerns surrounding your pregnancy when it came to epilepsy? What were doctors telling you in the past?
They were just, when I had gotten pregnant, the doctors here at KU were just very, be very careful. When you're pregnant, you have to be careful anyway, but just be extra kind of cautious not to do things that would trigger a seizure, and,
But tell us what the doctor told you about,
the doctor, yeah,
about you before, because that's very interesting.
I had gone in for one of my appointments and just told him I'm pregnant now, and he said, okay, we're going to have to find another neurologist. I'm not comfortable with this.
All right. Tell us why.
So, I think pregnancy is a normal condition for women, obviously, and so it's easily treatable, as it were. You don't really treat pregnancy, I guess. But when there's another disease, it makes a lot of people uncomfortable, OBs and neurologists alike. And epilepsy is actually very easily treated during pregnancy. I know Mallory went through that. So you manage blood levels. It's fairly straightforward, and it just takes a little extra effort from the mom. So
is it twofold? Is it a concern that a seizure could jeopardize the pregnancy, or is it also after you have a baby? Now you're responsible for a young child. You're at home. I mean, you go into a seizure, you have a young child. Tell us a little bit about what those long overall concerns are.
Well, I'll be curious what Mallory says too, but when women talk to me about those situations, they say it's both. They say people are like, how can you do this? Are you sure you can do it safely? Is this going to be dangerous for you? Is it going to be dangerous for the baby? And so I think you hear all those things. Is that kind of what happened to you?
Yeah.
Mallory, what was the biggest challenge?
With being
just having a baby, and did you have worries in the back of your head, or now that you have this implant, has it been a game changer for you as a mom?
With the implant, yeah, it's been a lot better, not worrying so much. But before, it was kind of a worry. I don't want my daughter to see any of this, to scare my daughter, because like we had just talked about before, the friends, it scared when we were younger, so I don't want to put that same thing on my daughter. And kind of like you had said, the people were always afraid that being able to take care of her right and know how to do it, well, that's not rocket science. You can know how to be a mother, just have to do it a little carefully.
You said, that's something you'd heard from when you were a child, young. You can't, have a normal life. You can't drive. You can't have kids. Kind of beating those odds. How does that feel? And what would your message be to maybe another kid in the 5th grade that's going through what you went through?
Just not to give up, not to lose hope with us, because it took a while to get where we are, but it is definitely worth it, and nice to feel, I guess, normal, how you put that.
Yeah, normal. None of us are really normal, but how thrilling is it, though, that she's able to do this because of the change in these treatments and technologies and science?
I mean, I think it's why Dr. Uisal, her neurologist, myself, and my partners, that's why we do this, is because epilepsy patients do everything that everyone else does. When we give our talks to our residents and medical students, we often lead it like, do you know anyone with epilepsy? And the people are like, no, I don't. And I guarantee that people do. 1% of the population has epilepsy. Just most people like Mallory nowadays are seizure-free.
Right, so they don't see it. They don't even know. Okay, so that's good news. That's really good news. Okay, so be sure to ask your questions. You can use the chat on YouTube or Facebook. You can tweet us or email us at the Medical News Network. Info is there on your screen. Let's check in with Dr. Dana Hawkinson on this Friday. How are you?
Yeah, hi, good.
So you've got some data for us, not just on COVID.
Right.
But there's other things, right? We're talking about flu, RSV. What do you got?
Yeah, and just like last year, we told you we'd be bringing these numbers for the health system here. So for active inpatient COVID infections, we do have 16, but we also have some other data that we're bringing you specifically for the respiratory viruses, RSV and influenza. And here you can see this is just with the University of Kansas health system here. These are the inpatient and outpatient positive tests for influenza. And you can see a very small number overall. And then if we go to the next slide too, we'll see that this is the CDC trend nationally. So you could see back from the middle of the chart until the right side, that is the most recent data. You can see those trends are going up for percent positive tests, but also total tests for influenza positive. So if you haven't got your influenza vaccine yet, now is a good time to go get it, because overall the trends are increasing, the number of positive tests are increasing as well. And then this we have, so this is just directly for the health system here. And these are our inpatient admissions for influenza. And you can see right now there's a very small number of patients that are in the hospital with influenza here at the health system. And if you remember back last year, we had quite a few at one point, but we are going to be following this trend now and delivering this information to you as well. And then we have I think one more slide, and these are our RSV positive tests, and this goes by week as well. And so you can see very few in the middle of the chart, which was earlier in the year. Now as we're getting to the most recent times, our trend is going up as well. The orange is pediatric, and the blue is adult cases. So overall, the trends of respiratory viruses and positive tests is going up. If you fall under the criteria for getting your RSV vaccine, now is a good time to go get it. And of course for influenza as well. And if you haven't had your updated COVID vaccine, it's a good time to get that as well.
Okay, I'll go do it all this weekend.
Yeah.
Okay. Hawk, thanks so much. Let's get to some questions from our viewers this morning. Megan wants to know, does the RNS device need to be maintained or recharged or checked in on?
So it doesn't need to be checked in on. When you started, it was every day that you download basically from your brain to a computer, and that stores all those ECOG informations that I showed earlier. And so then probably on a weekly basis, you probably did it. Then it goes from that computer to a secure server that NeuroPace hosts for us so that we're able to look at it. Otherwise, the device itself needs to probably be changed every 10 to 15 years. That depends on the settings for each patient. And we're hopeful the company is developing a new device where they say the battery will be like 20 or 25
Nice.
years. So we're very excited for that. Less surgeries.
So Ruth Ellen has a question. How are unexplained, and I hope I'm saying this right, syncope episodes? Is that is it?
Syncope.
Syncope episodes different from a seizure?
So,
And what are those?
Yeah, so epilepsy is an electrical disease of the brain, and then syncope is basically a blood flow problem disease. So when people faint, it's when the heart doesn't pump enough blood for any reason whatsoever. There are lots of reasons. The most commonly are very benign. But basically not enough blood gets to the brain, and so the brain needs blood, that energy, to function. So it just temporarily doesn't have enough energy, and then you lose consciousness.
So Yan Liang has a question. Is it possible for people who have experienced epilepsy as they age, do they face a higher risk of developing conditions like stroke or Parkinson's disease?
Not to our knowledge. Epilepsy is kind of contained in itself. It does have other kind of long-term manifestations. They have higher rates of depression and anxiety, for instance, and things like that. But we don't think they have higher risk of stroke or Parkinson's disease.
Is epilepsy genetic?
It can be, so not commonly, thankfully, and so, or maybe let me clarify that. It can be genetic, but it's not as often inherited. There are two main kinds of epilepsy: focal epilepsy, which is what Mallory has, and then generalized. So generalized tends to be more genetic, as it were.
So anything that she needs to be concerned about with Natalia as she gets older? Is there any type of screening, or is that still in the works? Is there anything she should be on the lookout for?
It's unlikely. Without, I don't know as much about Mallory's history, just I'm not her direct neurologist, but it's unlikely for people with focal epilepsy to be, unless she told me her mom had it and her grandma had it, or some kind of clear familial inheritance.
So she's just a mom. There's other things to worry about as a mother, is what you're saying.
Exactly,
I like that.
yeah.
Okay. Linda wants to know, can seizures cause brain damage?
So yes, we know that individual seizures probably cause microscopic damage that are probably of not clinical relevance to a patient, like they won't notice a change, but a lifelong time of epilepsy does. We talked about this increased risk of mental health issues, migraines. I know Mallory has migraines, so that's very common to have both of those. So long-term uncontrolled epilepsy certainly do think can be damaging.
Pauline is asking, do people with epilepsy qualify for disability? Mallory, what was your experience?
It was kind of hard at first because I hadn't worked long enough to get the disability, but after several times of trying, yeah, we had gotten it.
What do you make of that and that challenge for people?
Yes, so they certainly can qualify for disability. It's a legal proceeding, not a medical one, which is always very frustrating for patients. I don't think I need to tell Mallory that.
Right.
Many times they have to get a lawyer to help them.
But frustrating for you as a doctor to watch your patients have to jump through hoops.
Well, absolutely. We try not to make it about us, but yeah, I mean, because we're trying to do our best for them, and they know, it's when they don't have the resources to manage their own disease because sometimes they can't work and then they can't get disability. It gets to be this very vicious cycle.
Sure, and I'm sure you get an earful every now and then from it. So yeah.
I mean, we're mostly on the same, not mostly. We're on the same side as our patients.
Exactly.
So we're very frustrated along with them.
Exactly. So Lexi wants to know. This is just interesting. How can you tell if someone is faking a seizure? And I say this because I'm thinking of like social media or TikTok or something where somebody's doing something weird online and people are trying to decipher, what is this?
So there's a separate diagnosis that epileptology call non-epileptic events. And so usually you can tell pretty easily based on the history of what people tell you about it. And when you see it, a non-epileptic event looks a fair bit different from a seizure, or most commonly does. But True faking, that's like a different disease called malingering, so that's actually thankfully quite rare, but usually you can just tell from a number of clinical signs that a patient has.
Okay, so Travis wants to know what causes seizures besides epilepsy.
So there are all kinds of causes of seizures. So seizure is basically a symptom of irritated brain. So epilepsy is by far the most common reason. But one common thing is for folks with diabetes, if they have really high blood sugar or really low blood sugar, that can cause seizure. Alcohol withdrawal is perhaps the most common cause of seizures. So those are two of the more common medical causes of seizures.
Jeremy wants to know, when I think of surgery on the brain, it sounds very intense, and it's a lot, but it seems like the procedure and the recovery for this implant aren't so bad. Is that correct? Mallory, I'll ask you.
Yeah. I didn't even have really hardly any problem. You have the pains afterwards, like the nerve, I guess you call it nerve damage from it, but that's otherwise, yeah, you had really no problem with it.
Sharon wants to know, what is benign children epilepsy? Can that be outgrown?
Yeah, so there are several epilepsies that begin in childhood that they do resolve by the time the patient's a young teenager. Most new research has not indicated any epilepsy is benign. The ones that I think she's referring to are called the benign, well, they've been renamed. They're no longer called the benign childhood epilepsies, but people have shown that there's higher rates of needing help in school and then of mental health issues as well. So they're not benign, but they do self-resolve commonly.
Mallory, you mentioned earlier you are back to driving. Is that correct?
No.
You are not back to driving. Okay. Is that ever a possibility?
Yes. That's,
okay.
Dr. Uasal they've teased me about it as my seizures have stopped.
So are they waiting for a certain amount of time for you to say, we feel comfortable with this? How does that work?
I think, isn't it a year that you have to wait without having?
By law, it's 6 months, but it's actually often the patients that they feel nervous about it, and understandably so. So I suspect, I suspect as much as Dr. Usal has waited, I think you've probably been like, do I feel confident to do it? And obviously we're encouraging, but at the end of the day, the patient makes that decision.
How freeing will that be?
Oh, wow, very.
Yeah, it's like those little things that we take for granted. We don't realize we all jump in our car and come to work and go do our thing. But for you, being able to be out there and get your kid where they need to go and live life, I love it. Paul has a question. Is Keppra a safe medication for seizure control? Does it affect organs over time? And tell us what that medication is. Yeah,
so Keppra, or the generic name is levetiracetam. It's kind of a mouthful. That's why we all call it Keppra. But yeah, it's very safe medicine. It's one of the most commonly used seizure medications. It doesn't interact with other medicines, which is why we like to use it so commonly. And to our knowledge, it doesn't have any long-term side effects that are like bone loss or something like that. Some of the older seizure medicines have that. It has a risk of some side effects like all seizure medicines do, but no long-term ones. So in other words, if you stop it, and any side effects you have should stop as well.
Last question is from Peg. Does a febrile seizure in a child increase the risk for more seizures or epilepsy?
That's a complicated question, Peg. So it can. So there are simple and complex febrile seizures. So simple, we don't think increases the risk, but more complex ones, so that means that it comes from just one part of the brain, or if it's status epilepticus, a febrile seizure that doesn't stop, we do think that does actually increase the risk for the kind of epilepsy that Mallory has.
Yeah, complicated questions. That's why we have you here. I want to get our takeaways today, and Dr. Landazuri, we'll start with you. If someone's watching, knows somebody with epilepsy, has epilepsy, what's the biggest takeaway?
I think two things. One, that people with epilepsy are normal and you should treat them as such. You interact with them like anybody else. If they have a seizure in front of you, all you do is you keep them safe, which can be as simple as laying them down and protecting their head. There's not too much. The other thing is that for people with drug-resistant epilepsy, in other words, you've taken 2 or 3 medicines and it's not been fully controlled, it's probably good to consider talking to a neurologist who can consider surgery with you. So obviously the neurologist doesn't do the surgery, the neurosurgeon does. But at a place like KU, we have this incredible partnership with our 3 neurosurgeons who do the epilepsy surgeries, and so you should be at a place that can explore that with you.
All right, I do want to back up though on something. You said protecting the head if you see somebody having a seizure. What else should we do if we see somebody or suspect somebody having a seizure?
Yeah, the only other thing is really roll them on their side. That's so if there's any saliva that it goes out of their mouth instead of back into their breathing system or something like that. But otherwise, yeah, so just you don't restrain them because you can dislocate shoulders and stuff like when you do that. And don't put anything in their mouth. That's a common misconception, but we're more worried that they're going to choke on whatever you put in their mouth rather than protect them.
Okay, wait it out or call 911?
So most seizures stop after 1 or 2 minutes, and then you don't need to call 911. I would say if you're not familiar and you're uncomfortable, you should call 911 for help. Paramedics obviously are very well trained for it, but most people with epilepsy will, they'll wake up afterwards and be like, oh, this happened, and they don't necessarily need to go to the emergency room. I think epilepsy patients are very savvy about knowing when they need help and when they can kind of go about doing whatever, and I expect you might have had that experience, Mallory.
Yeah.
So what do you want people to take away from your story?
Just like I said before, just do not give up on this, and there's a lot of things that they're coming out with now just from the several years that I've dealt with it. It's just amazing what people can do and be able to do now, the things that they are coming out with, and other than just the medications.
And what's your big advice? Again, I want to go back to just you lived it, you were a young kid around other kiddos, and just what advice do you have for parents who are watching their kids experience it? What can you advise them or comfort them with?
I mean, just to kind of stay calm with it all and try to learn your best about all the things with epilepsy, and kind of like the doctor said here, that there's still a normal person with it.
Find new hobbies and find new friends?
Yeah.
Okay,
Yeah.
That's okay to do. All right, thank you both for being with us today. Really, really important conversation. Thanks to all of our viewers. You had a lot of great questions today. Have a great weekend, and we'll see you back here on Monday. Coming up Monday on the Morning Medical Update. At a certain age, your bones get weaker, and for women, menopause can make the weakness even worse. I'm Jessica Lovell on the next Morning Medical Update, protecting your bones in the lower back especially, thanks to new research into hormones. Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.